improvements in surgical techniques, post-op care, immunosuppression. But as you can see in this graph, is that the demand for transplant far outstrips the number of organs that are available. So the number of organ transplants, they have only increased over all these years. And although we do not have, none of the countries in the world have the capability to cater to the number of transplants that are required. Even in countries like US and most of Europe, Western Europe and Australia, where the systems for organ transplant and donation are quite well streamlined, even they are not able to meet more than 20 to 30% of their waiting list. And therefore, I say that transplant is a victim of its own success, because although it's a very successful modality of treatment for end-stage organ disease now, it can't meet the demand that is there, and therefore it's unable to do justice to patients. Now, this demand-supply gap is not only huge, it's generally about 4 to 5 times, and this is again not just in India. We are talking about all over the world. No country in the world has been able to meet this shortage. The waiting list mortality, depending on which organ you're talking about, it could go from 15 to up to 50%. And most of these patients, whether it's for kidneys, for livers, for heart, for whatever organ, they lead a really poor quality of life while they are on the waiting list. And again, depending on which organ we are talking of, organ failure we are talking about, there are patients, the waiting list mortality, the mortality risk on the waiting list could range from 10% to up to 50%. So that's again a huge problem. So there are thousands of people who are waiting for an organ transplant. We don't have the capability to transplant everybody. So you have to ration some way. And then once you start doing the rationing, we get more ethical problems along the way. So this entire demand supply gap in organ transplant is because we don't have enough for everyone. That is the core problem. Because the demand for transplant is too much, the organ availability is not as much. And, this, like we said, it's a problem that exists everywhere. Now, there are several conflicting principles, ethical principles that we are going to talk about, which are going to be important for us to understand this problem well and how to sort of rationally think about it. So the first is respect for autonomy. That's like the most important principle, ethical principle, which is why we take consent. So when you do a surgical procedure on any patient, you take consent. And this is important even after somebody passes away. So not only do you take consent for somebody undergoing a procedure or a surgery, or even let's say for blood transfusion, but even for somebody donating their organs after they pass away, there has to be a consent. That is the principle of autonomy. Then there is principle of non-maleficence, which is part of the Hippocratic Oath, which means that even if you can't benefit any patient, as a doctor, you should not harm anybody. That is the principle of non-maleficence, which I'm sure most of us are aware. Then there are principles of justice and principles of beneficence. Now, what that means is that as a doctor, it is our responsibility that you try to do benefit as many people as you can. Now, while this is ideal, it's obviously not possible. So, for example, if we were to say that, let's vaccinate every single person in this world. Now, that's a good intention and it benefits everybody. But is it possible? No, it's not possible for whatever reasons. Now, in that situation, what do you do? Who do you prioritize? Which person gets priority in the vaccination that is available? Then the last principle is justice. Justice is when you try to say, okay, if there is a person who is sick, then that person should get the maximum attention or the maximum resources. And the person who is not so sick should not get as much attention or resources. That's the principle of justice. We're going to look at all this very soon, very quickly. But then these are the 4 basic principles, ethical principle on which all our discussion is going to hover around. Again, there are 2 types of transplantation primarily. One is disease donor or cadaveric donor transplant, and the second is a living donor transplant. The third type, which is donation after circulatory death, is a type of cadaveric or disease donor transplant, which we are going to touch briefly. But as I'm sure all of us know, the living donor transplants are generally done for either liver or kidney transplant. Kidney transplant because we have two kidneys, so we can donate one safely. Liver because it can regenerate, therefore you can donate part of the liver, and therefore it's possible to do a living donor liver transplant. Now let's look at the first type of transplant, which is living donor transplant. So there are three principles out of the four we discussed that are applicable here. First is autonomy. So nobody should be made to donate part of their liver or kidney without their consent, without autonomy. So it should be a totally autonomous decision. It should not be, there should be no coercion, no force at all. The second is non-maleficence, which means that do not cause any harm, which also we understand. And this should be either planned or unplanned, which means that it should not be an act of commission or omission. And then the third is we should benefit the person who we are treating. In this situation, it is not possible to benefit the person who we are who's undergoing surgery. So we are not doing it for the benefit of the donor. We are doing this for the benefit of the recipient. So while two people undergo surgery, only one of them benefits. The other one is doing it voluntarily, autonomously. So therefore, we'll see how it goes, right? So for donor autonomy, the WHO says that you have to be either genetically, legally, or emotionally related to the recipient. You should give informed voluntary consent. There should be professional follow-up, which should be ensured and organized. There should be common selection criteria. So it's not that you select one person on one day and another person on one day using different criteria. You have to have common criteria, and you should follow those criteria for anybody who walks in. And then again, not by force, only by voluntary consent. Minors and legals should not be donating. Now, there are some exceptional situations, such as identical twins. In those situations, there should be a system through which the consent should be taken. Otherwise, for all practical purposes, minors and legally incompetent people, meaning people who cannot give a legally valid consent, for example, a mentally incompetent person, should not be, is not able to give a consent, or the principle of autonomy will be violated if these people are told to donate or allowed to donate. Therefore, they are encouraged not to donate. So most countries have laws which support this. So in order to ensure this, what we do is we do a very thorough evaluation of the recipient, which means a lot of testing. We identify, evaluate, and talk to a matching living donor, which means that here you're making sure that they understand the benefit of this procedure, and that the donor should not get harmed. Then an independent psychiatrist or a donor advocate takes the consent of the donor to ensure, and this is done in absence of the recipient or in absence of any other family member. So this is to ensure the autonomy of the donor. Now, sometimes the donor is afraid of telling the doctors that they don't want to donate in front of their family members. So here is an opportunity for them to privately tell you that they don't want to really donate and they are under pressure from the family. And in which case, what we do is we find a medical reason to make them unfit for donation. Then there is an authorization committee which is made by the government, and they again interview the donor and the recipient independently, and which is video recorded. And once they approve, that is when we go ahead with the transplantation. Now, this is to ensure that we follow all these principles and do not violate them. Now, the WHO principle also says that it should be not rewarded by any money, because then it will become like a commodity, and it will be very sad the day we start making human organs a commodity. And therefore, the WHO says, and we all follow, that it should not be for any monetary payment. But if there are any expenses incurred by the donor for the process of donation, then they can be reimbursed. But as far as the physicians are concerned, we have to be sure that we do not engage in any transplant procedure where you are unsure that the donor is not doing this on their own will and the principle of autonomy is being violated. So again, while living donor transplant is life-saving for the recipient, the donor's altruistic act does violate the Hippocratic oath of do no harm. So we have to be very mindful of this. Now, like we said, the beneficence of the recipient against non-maleficence of the donor is the balance that we need to maintain, to manage. And therefore, what we do is we use what is called as double equipoise. So on the x-axis, the horizontal axis, you see that there is a recipient benefit. The recipient benefit increases as you go along here, and the donor risk increases as you go along here. So as a unit, as a doctor, as a team, at some point you have to decide where is your comfort level. For what amount of donor risk will you accept a certain recipient benefit? Beyond that, you have to say no. Even if the recipient is very sick, or even if the donor is very fit, you just have to say no. And as a team, you should be able to follow this principle. Now, what is the acceptable risk? Although I would say that probably the risk is lesser than this in reality, but this is the documented risk. For a kidney donation, it is 0.03 to 0.06%, which means that 1 out of every 3,500 donors will have a risk of mortality. For left lobe of the donor, liver donation, it's about 0.3, 0.2%, which means 1 in 500 donors who donate a left lobe could probably be risking their lives. And for right lobe, it's about 0.5, which means 1 in 200. Now, as a team, are you comfortable with this number? Ideally, I would like 0% risk to the donor, but that's not possible because there is an operation involved, which is major. There is anesthesia involved. There are several places at which there could be risks. So therefore, we need to figure out whether this risk is acceptable to us or not. So there are several systems that have been devised to try to balance this risk. So there are several scoring systems, such as in liver especially, there are the DRI and various other scoring systems. Then for recipient, there are MELD scores and other scoring systems. But there are several scoring systems that we use right in the middle that take into both the donor as well as the recipient parameters. Now those balance both the risk of the donor as well as the recipient quite well. For kidney again, sorry, there are similar risk scores which are called differently, but we just have to know that there are risk scores that you can use to determine what is the recipient risk and what is the donor risk. Similar to the double equipoise we just saw, sometimes there are situations where there is another factor. For example, if there is a pediatric patient who is going to undergo a transplant, now the benefit to the recipient is so large, so huge, because a 1 year or 2 year old child getting a liver or kidney transplant, the liver is going to last them a period of 60, 80, 100 years compared to somebody who's undergoing transplant at 60 years. So therefore, the risk of donor, of the benefit of the recipient in a pediatric transplant is so large then that a transplant team may accept a higher donor risk based on the triple equipoise of the principle. And similarly, in India and Japan and Korea, when we did not have cadaveric transplants, we had no choice but to do living donor transplants. Although at that time, living donor transplants had much more complications. But then we started doing them, we started getting better at them, and now the complication rates are actually lesser than disease donor transplantation. So the point is that in certain situations, the double equipoise alone doesn't work. There is a third factor, another factor, which also has to be taken into account and which makes the thing a little more difficult and complex. Now, although we saw what's the typical risk in the donor and the recipient, especially in the donor, I was surprised to find these two studies done by the same group. So there was a survey done by this group to find out what's the acceptable risk that somebody will, a risk that people will accept to be a living donor for a family member who they love. So the first study is from 2001. And this is from people who are non-medical, outside medical community. And people said that they were willing to accept up to 80%, 20% risk for the donor. They were willing to accept a survival of 80%, about 80% for the donor, and for the recipient, 55%. So imagine a common man thinks that even in 20% chance that I die in the donor operation, as long as my family member has a 50% chance of surviving, I am willing to do it. That was what non-medical people said. They followed it up with another study in 2003, and this time only transplant surgeons, liver transplant surgeons, who very well knew how this risk is and all that, right? Now, here again, the results were very surprising, because the transplant surgeons themselves said that I would accept a 10% risk for a 80% success of my family member as a recipient. Now, this is 20 times more than what is the current risk. So that's a very surprising thing. But anyway, I'm just saying that the perception that people have about what their acceptable risks are, and the acceptable risk as a doctor when you're administering treatment to patients may be very different. That brings us to organ trafficking. So 1994 is when the Organ Transplant Act was passed in India. Before 1994, there was no law. So even if you did a transplant or if you stole a kidney from somebody, it was not illegal because there was no law. So using this opportunity, a lot of people became agents, and they went to villages in small villages of India, and they convinced people that they should sell their kidneys for money. And people did. And there are entire villages in India where nobody has more than one kidney. Now probably they do, but at that time they didn't. So the point is that this is another new a problem that has happened, and this is not just something that is in India. There are several countries where this problem exists, and that is because of the huge difference in the annual income between different countries. So countries like India have typical donor countries which are in red, where the annual income is about $500 a year. And there are countries where there are typical recipient countries like the US, some European countries, the UK and Australia, where the annual income is about $53,000 a year. So therefore, this turned out to be a very lucrative, although unethical way to do transplants. And this was a vicious cycle, because poverty as well as this was a vicious cycle. And that unfortunate reflection of the society was also seen in transplantation. So, to address this, first of all, we defined what was organ trafficking. So this is a very elaborate definition on the screen, and we sort of know and understand what it is. But basically, when somebody sells their organ for transplant for money, that's what's organ trafficking. But there has to be a differentiation made between organ trafficking and transplant tourism. So when patients travel to another country for a transplant, not for the purpose of buying or selling or receiving organs, that is transplant tourism. Whereas when they do it for those purposes, leading to inequality, injustice, discrimination, coercion, exploitation, that is organ trafficking. So this has to be very clearly differentiated, because organ trafficking is bad, transplant tourism is not. And that is primarily because there are so many countries where there is such a lot of discrepancy in the amount of facilities, infrastructure, expertise available in different countries. So to resolve this, there was a meeting held of 150 representatives from 78 countries in 2008, which was then updated in 2018, called as the Declaration of Istanbul, where the steps how to stop organ trafficking all across the world were discussed and documented. So here the problems are not just that you're doing an ethically wrong thing, but also because the donor and the recipient's safety is at stake here. Generally, these transplants are done in very poor infrastructures, which compromises both. And this has led to Declaration of Istanbul has led to ban on all types of advertising for soliciting organ for transplantation. Sorry. And again, transplant tourism or ethical travel for transplant is okay. That's again because there is such a huge difference in the cost of doing a transplant across different countries. And India is one of the places where I think that you can get a very good quality transplant for probably one of the lowest cost in the world for about the same quality. Sorry. Now we come to the second part, which is a disease donor transplant. Now here the ethical principles in play are three, which is justice, utility, and equality, in addition to autonomy, which is common. So justice, like we discussed briefly, is you give the organ to the sickest patient first. It doesn't matter. Now the problem when you do this is that the sickest patient will have the worst outcome. Now you're going to give a transplant or an organ which is rare and scarce to the patient who's the sickest and therefore has the least chance of survival. Not only that, the transplant is going to be the most expensive in that patient. Okay. Now the second is utility, where you try to maximize the number of years that you get out of that organ. So you transplant patients who are young, who are stable, who have the highest chance of survival. And using this principle, utility, you will get the best and the most cost-effective system that exists. But the sick patients will not make it. The stable patients will live the longest. The third principle is equality, where patients say that, we don't care who's sick and who is healthy. Everybody deserves equal chance. So everybody should get the same access to organs, and that is equality. So, patients or doctors or as a community, we don't bother about any of this. We just look at one parameter, which should be equal for everybody, irrespective of age, gender, sickness, etiology, economic status, location, nothing. Only equal access to all of this. Now, to ensure that we follow these principles, what we do is, when we do a recipient evaluation, we put them on the waiting list. Here, we're trying to make sure that we follow the principle of equality so that everybody has access to get to the waiting list equally. We also try to see if the patient who is more stable is going to be also on the waiting list as much as a sick patient. Then when the donor is or the family wishes to donate their organs, then there is declaration of the brain death, which we are going to briefly discuss. But then the organ donation consent, which is based on the principle of autonomy, has to happen before organs can be retrieved from the brain dead donor. So even after they have passed away, even after the person has died, the principle of autonomy holds that organs cannot be taken out unless there is consent. And then there are several situations such as non-directed allocation system is there, which means that we decide which of these principles is important for us: justice, utility, or equality, which we'll see briefly. And then retrieval is done and transplantation is done, right? Now, quickly about brain death, I'm sure most of you will be aware of this, but when there is severe injury to the brain, either because of head injury or because of stroke, they have permanent damage to the brain. Now, brainstem, which controls your heart and respiration, it still functions. So because of that, you can still be on the ventilator, you can still be on some inotropic drugs, and then you can still have good perfusion of all organs. And this is recognized by the law in India. This is different from coma because in brain death, the respiration has stopped because the trigger from the brainstem has stopped. So you have to keep them ventilated. There are no body movements, no stimulus, nothing. In coma, there is respiration which is spontaneous. There is some movement sometimes, and then they can be off life support most of the times actually. So in India, we do about 0.5 organ donations per million population approximately. In Spain, it's about 35 donations per million population. They have a smaller population too. But then the potential of organ donation in India is so much more than what we are currently doing. If this 0.5 were to just go to around 2, not 35, not 25, just 2, then we'll probably have no waiting list in India actually. So there's various surveys done, and we know that it's not really the awareness about organ donation in metros that is such a big problem. But if that's the case, then why the organ donation rates are so low in India? Anyway, so we are going to not discuss it today, but that's one of the facts is that we have very low organ donation rates today. The WHO principle again for autonomy is that no cells or tissues can be removed without consent, which we do as part of the process. Now, here is an interesting thing. So we follow what is called as opt-in system, which means that when somebody wants to be an organ donor, they have to say that they want to be an organ donor, which means that either before they've died, they sign a donor card, which is an expression of their intent to donate, but not a valid document legally. Or their family, after their death, they sign the consent, and then that's how the donation happens. Now, this is possible by altruism, by community spirit, but also people have thought that it could be driven by financial incentives or by non-financial incentives. However, in India, only altruism and community spirit is allowed. Financial and non-financial incentives are not allowed. There are several countries where they have what is called as presumed consent or opt-out system. Here, it is assumed that the person is going to be an organ donor unless they have said or signed a document saying that they do not want to be organ donors. And this can lead to coercion because the country or the government is basically putting giving consent for donation instead of the person. So that partly violates the autonomy principle, but there are several countries where it works quite well. Now, some of the ethical dilemmas here, supposing there is a patient who has alcoholic liver disease, which is a self-induced liver disease. So does that patient deserve the same chance on the waiting list as somebody who has, let's say, liver cancer? Or what about smoking? If somebody has interstitial lung disease because of smoking versus somebody who has interstitial lung disease because of other reason, do they deserve the same chance? What about metabolic syndrome? Today, we have reached a stage where almost 30 to 50% of patients on the waiting list, either for a kidney or a liver transplant, are because of metabolic liver disease, such as fatty liver disease and chronic kidney disease because of diabetes or hypertension. These are also self-induced diseases. So, because you can control your weight, you can control your diabetes. So, do these patients deserve the same chance as others? So, the other ethical questions are, supposing there is a patient who needs 2 organs instead of 1. So, the benefit that the person is going to get is much more than a person who's getting 1 organ. Should such patients get priority on the waiting list? If a patient has undergone 1 transplant in the past and now has a failed liver or kidney or heart, should that person get priority on the for the next organ, or should a person who has never gotten a chance on the waiting list should get a chance? So there are several such ethical questions which, time permitting, we're going to pose some of these questions to you in the end. So the guiding principle for this is the allocation of organ should be guided by clinical criteria and ethical norms, not by any other consideration. Whatever rules of allocation you make should be done by a committee, and they should try to balance these principles, the 3 principles that we discussed of justice, equality, and sorry, I'm forgetting. So then it gets even more complicated, because what we do is sometimes we try to then push boundaries to make progress. Otherwise, we will never make progress in this field or any field. So therefore, when we have a 40-year-old person who has died and has healthy kidneys or healthy liver, taking an organ from that person is an easy decision. But would somebody take, or should you offer an organ from a person who is 80-year-old or somebody who has slight fatty liver? Now there you are increasingly complicating the ethical issues also, because now you're probably giving a suboptimal organ to one patient and optimal or a good quality organ to another. How do you decide? So again, a little brief about DCD, which is donation after a circulatory death. So we have to understand that only 2% of deaths are cardiac or brain deaths. Rest are all the standard cardiac death where the ECG becomes flatline and you die. It's how it happens in Hindi movies. How it happens in every medical college. Brain deaths, you'll probably see one or two, but generally you will not be able to see it during your training also. Now, how have we progressed from, uh, you know, in the definition of death over all these years? So in the past, when we did not have a stethoscope, we did not have an EKG, nothing. There's only one way to figure out if somebody has died and when they stop breathing. So you watch respiratory movements, and if they stop breathing, you say that they've died. Then, stethoscope and ECG became available, and then you figured out how to take pulse. And then you said, okay, respiration can come back because, you can drown and then you can start breathing after 5 minutes. But if the heart stops, and these are the guys who will never be alive again. So you do a ECG, you demonstrate flat line, and if it's flat, then you say that this person is dead. Then came ventilators. And then we realized that, even if somebody's ECG is not flat, they could still be dead because their brain is irreversibly damaged. And therefore, now we have brain death. So how do you diagnose brain death? The heart is beating, the respiration is supported, but you look at reflexes, you look at some apnea test, which is a test by removing the ventilator for a few minutes and then check the respiration. And then EEG and brain angiography. And you can say that, okay, this person is dead because the brain is not functioning. This person is never going to wake up. And then now we have complicated it by adding ECMO, because now with ECMO, you can potentially have a person who can never die. So therefore, now we have identified that there has to be permanent cessation of capacity for consciousness, breathing and brainstem function for somebody to be dead. So the definition of death has gotten more complicated over the time. These are the various categories of donation after circulatory death, which we won't go into details today. And this is how you think about somebody who's got a brain injury, whether they are brain death, whether they are, circulatory death, and how do you go about organ donation in these various situations, right? Now, I'm going to pose a few questions, and I welcome and encourage all of you to participate, please. So there are several situations, difficult situations. Based on the ethical principles we have discussed, I would like your comments and inputs. So there is this guy, Robert, and he carries a donor card and has signed the NHS organ donor register, which means that he wanted to be an organ donor, but then he passes. And then the transplant coordinator approaches their family, and the wife says no for donation. Whose wishes do you carry out, the Roberts or his wife's?
What does the law say?
So the law in India says that the family has to make a decision. So even if the person said that they wanted to be organ donors, they cannot be organ donors unless the family says. So the next of kin is the family final decision maker for such a scenario. Let's go to the next one. Now, to make it a little more close to you and close to us, I've made this a real case actually. So a 21-year-old medical student has consumed rat poison with an suicidal intent due to personal reason. This was a third attempt. Before she slipped into coma due to acute liver failure, she was evaluated by psychiatrists and deemed high risk for future attempts. Her brother is willing and a suitable donor for a liver transplant. Would you offer a liver transplant to this patient? No?
I think most people are saying no.
Yeah. So the thing is that, okay, supposing you were not to harm the brother here, supposing you were able to get a cadaveric organ for her, what would you do then? So you're not going to harm the brother. At the most, what will happen is that the cadaveric organ will go waste, and she may or may not She will survive probably, but we do risk that in the future she may attempt a suicide again. What would be the right answer then?
If anybody would like to unmute and talk, please just raise your hand.
Okay, so generally there is no's here I'm seeing, and I tend to agree because again, like I said, none of these questions will have a correct answer. There are no correct answer when you're having a discussion about ethics, So so if you do a transplant, then it has to be followed up with counseling therapy to ensure that there is a good understanding of what she has got. But if you were to decide not to offer it to her and to offer it to somebody who did not have that risk of losing the organ, then that's also a fair decision. Okay, now Frank, who is in need of a kidney transplant, does not have a suitable donor, but his wife could donate part of her liver for a liver kidney swap transplant, which means that there's another family who needs a liver transplant, and Frank's wife could donate the liver, and the other family's donor could donate the kidney, and they could do what is called as a swap transplant. Now, you know that the risk of donating a kidney is not the same as the risk of donating a liver. Would this be fair to do such a swap transplant? So I'm seeing a lot of no's here, but what's the harm if there are two people whose lives are getting saved? One from kidney failure, one from liver failure. Yeah, so now there's yeses. So this is the interesting thing of ethical discussions, So I would do it, but they have to understand that the risks that the two donors are taking are different. So they are not taking equal risk for the same operation, right? Great. Now, a patient who was undergoing an operation for liver transplant for acute liver failure becomes unstable during the transplant. And acute liver failure patients are like that. They can become really unstable even in the 4 or 6 hours that you are doing the transplant. So unfortunately, the acute liver failure patient dies during the operation. Now you have already done the donor operation and you have removed the donor's liver. What do you do with this liver? Such a liver, by the way, is called as an orphan graft. What do you do with such a organ? Have you before you answer, have you so the donor only consented to giving this liver to this recipient? The donor did not consent for anything else. The donor only consented to donation because this was going to somebody that they loved. So there is a option called as preserve. Somebody said preserve, Varshini, but then you can't preserve it for more than 6 to 12 hours. So how will you inform the donor? Because the donor is anesthetized.
But you can't do anything else with it, right?
No, I'm asking whether you can or wake him up.
No.
No, this is in the middle of donor surgery, because once you've removed the donor's liver also, it takes about 2 hours for finishing the procedure, closing up and things like that. So the thing here is so we don't have a clear answer anywhere in the world for what to do with orphan grafts. And in such situations, which have been rare in the world, there are different approaches that have been taken. One is that, like a lot of people are suggesting, is to give it to another patient who is on the waiting list by taking consent of the next of the kin or the family member, which is a very reasonable thing to do. And a lot of countries have laws which are in accordance with this. But then it is not an easy thing to do. You'll have to just trust me on this. That's a very difficult situation. Anyway, a convicted killer who is due for execution in a few months requires a heart transplant. And after several months on the list, he receives a heart offer. Should the heart be offered to him? So as a convict, he has right to equality. So keep that in mind. And then So with that ethical principle, there are yeses coming, but you know that this heart could be used in this person for a few months because that person is certainly going to be executed. Whereas if you give to another person, it may last for 20 years or maybe more. So, yeah, so there are points saying that the utility is less, but you're right. So again, what the point I'm trying to highlight from these scenarios is that no matter what decision you make, you are going to violate one or the other principle. So I'll sort of stop here. And last question: if a brain transplant becomes feasible, whose brain would you like to have? Supposing an unfortunate situation, you are there. Albert Einstein, Tesla, Narendra Modi, Bill Gates, Steve Jobs, Mukesh Ambani. Whose brain would you like to have if you brain transplant were feasible? Okay, there is a lot of Tesla and Einstein fans here. But before you answer that question, I have another very quick question. If ever brain transplant becomes feasible, is it the brain you're transplanting or is it the body you're transplanting? Is it body transplant or is it brain transplant? Think about it, because it's just the brain so this is what Sir Arthur Conan Doyle said. I'm just a brain, dear Watson. The rest of me is just an appendix. So your entire body is just an appendix. So it's the brain really that is not being transplanted. It's the body that we are transplanting at that stage. Wonderful. So there are several dilemmas, and no matter what decision you make, you're going to violate one or the other ethical principle. Some of these we have discussed, but as a doctor, as a medical team, our role is to discuss this beforehand, reach a balance where you feel comfortable that you're balancing all the principles and you follow it. Once you write it down, you follow it. Then you should not change it for a particular patient. That is the take home message for today. Thank you very much. Happy for any questions.
If somebody has a question, please do unmute yourself and ask. Dr. Mohanka, I have one question.
Yes, please.
When that part about the liver being already taken out and the recipient dying, I mean, you can't put the liver back, right?
No, it won't be.
I mean, in what situation would the person who's the donor not want the liver to be used?
So the liver cannot be put back into the donor.
Yes.
It can be used for any other patient or discarded.
Right. So
even if you said discard, it will not be a wrong, ethically wrong thing to do. Because you do not have consent for that.
Yeah, but I mean, it's already out and I'm sure the donor would.
So it is logical.
Has it ever happened?
It has happened, but it has always been used. It has never been discarded.
I think somebody is asking, can you simulate?
There are two hands also. So there are, can you simulate totipotent cells to develop into a particular organ? Very interesting. And yes, the answer is yes. So what happened, so there are two types of stem cells. One is embryonic stem cells, which can practically be transformed into any type of cell you want. And the second is mesenchymal stem cells, which can only transform into certain types of organs, or generally they help develop or in culture certain types of cells. At one point, we were making great progress in embryonic stem cell research until 2002, when Bush Jr. realized that people could very soon clone people. And then you could raise armies and you could do a lot of unethical things with that. And then from that day, embryonic stem cell research has been stopped all across the world. And only 3 or 5 embryonic stem cell lines, which are very tightly regulated, that existed until that point, have been allowed to continue for research in the future. And that even today, there's the same thing. So you could potentially convert a embryonic stem cell with the right technology, with the right environment and the right enzymes and right hormones into any type of cell you want. But that research has, for all practical purposes, been stopped because the potential for harm that you could do with such is much more than what you could actually benefit from it. Because, you know, if you get TV, everybody thought that you're going to watch Discovery Channel with it, but nobody does. So every technology can be used and misused. The potential of embryonic stem cell misuse is much more than the potential benefit. That's why the research has been stopped. And there are 4 hands up. Anybody can start, please.
Aboli, let's start with you.
Hi, doctor. So we all know that minors can't give consent for organ donation, but we have seen cases where, especially in bone marrow transplant, people are like there have been cases that people have conceived only to transplant bone marrow. Like,
Correct.
how ethical is that?
No, it is absolutely ethical. So again, I'm saying that, so there was a very classical case of 2 sisters, Lama sisters, they're called as, and they were identical twins, and one of the sisters developed kidney failure, and she was only 12 years old. Her identical twin was again also 12 years old. So she wanted to donate. She went to the hospital, they refused. She went to the state, they refused. Then she eventually went to Supreme Court, and there she said, "Ki, I want to donate," and court said, "No, you cannot donate because you are a minor." So she said, "Okay, so in that case, what if I die? Can I donate after that?" So then the Supreme Court sort of got shocked, and they said, "Okay, no, you can donate." So since then, in almost all countries, the laws permit donation by minors also under very specific situations. And there is a process that you have to go through to make sure that they are not their principle of autonomy is not violated. So it is possible for minors to donate even in India. But so for disease donation, there is no problem. The parents can consent, and the minor can also be an organ donor. But for living donation, it is very, very tightly regulated. It is not impossible, but it is difficult.
Okay, thank you.
Inesh, would you like to ask a question?
Yes, ma'am. Good evening, sir. Thank you so much for the talk. I had just one small question. Regarding the same liver transplant case that you had mentioned about this person anesthesia, since the person is anesthetized for a duration of 6 years and he's not in a position to give consent, so can we ask his kin, his family members, that we can donate the liver instead of discarding it?
Yes. So that is what typically is done. But again, even in that situation, the person's autonomy is being violated. So if there is a person who is incapacitated because of being under anesthesia or has passed away, then the next of kin is the right decision maker. And therefore, in this situation, the next or the family member are the right people to ask. But you have to understand that the family may be so devastated at that point that they may not be able to make a decision which is so giving. You know, it may be logical, reasonable when you're sitting and discussing it outside that situation, but they could be so, it is a very difficult decision for them also to make.
Yeah, I have a follow-up to that. Do you take any kind of, consent beforehand that in the event of such and such?
No, this is too rare a situation. So typically when you take a consent for any problem in any surgery, it has to be at least reasonable chance of that happening. So otherwise every consent form will become so large. So therefore any risk that is at least a few percentages, 0.1% or 0.01%, there has to be some 1 in a lakh chance at least for that to happen. So otherwise what will happen is that when you give somebody a penicillin injection, and if you have not taken consent for anaphylaxis, then you could be sued in the court. So therefore, the court understands this, and the courts, they want you to take consent for things that are reasonable, that have reasonable likelihood of happening. This is not one situation where you will encounter.
Pankhuri, I think you have a question.
Yes, ma'am, I did type it in the chat because I probably feel it could be beyond the scope of this talk considering we are talking ethics. But I see that we see a high awareness and or positive attitude amongst the population towards organ donation, but we do not see anything translating into practice. So as something that we take back from this webinar, what do we as medical students, apparently 100 of us today here, how do we contribute in tilting this scale and becoming a positive stakeholder?
So this is very easy to answer, but very difficult to do. And so what has happened over all these years is that the trust between doctors and patients in India is not very high. It is unfortunate, but that is a difference I see between how medicine is practiced in the West and how it is practiced in India. When I say that, what I'm saying is that when a patient goes to a doctor, and if things are all good and the patient recovers well, then doctor is God for them. But the moment the patient doesn't do well, then they see a lot of evil in the doctor. And they, even if the patient recovers, sometimes they think that the doctor has overcharged them and things like that. And that stems from the fact that inherently we don't trust our medical system and doctors very much. You know, we go for second opinions and third opinions all the time. So therefore, we don't have like a blanket trust, which is there in the West. You know, so when you go to a hospital, when you go to a university, or when you go to a community hospital, or when you go to a doctor in the West, typically you don't even know who the doctor is going to be. Typically, the doctor you see in the clinic and the doctor is doing your surgery, they're totally different. So therefore, this is the reason why a lot of people do not consent. And even if there are 2 people in a family of 10 who want to be sort of supportive of organ donation, there'll be 8 people who will say no. And it is safer to do what 8 people are saying rather than what 2 people are saying. That is one. Second is, even doctors, as doctors, we are a little afraid of asking the patient for organ donation, because the moment you say, you don't know how the patient is going to react or the family is going to react. You know, there have been instances where doctors have been hit because they asked such a question. And if the level of trust between the doctor and the patient family is anyway low, then we fear very much that, you know, first of all, they're dissatisfied with the treatment, or they're worried that they're have been overcharged, and now you're asking this question, they're really pissed off. You know, so therefore you try to avoid it, and then avoid the question for 2 more days. From in that 2 days, the person will go from being a brain dead to a cardiac death patient. Then you don't have to face this uncomfortable situation. So making brain death diagnosis happen and organ donation happen is something that will happen only when we as doctors are convinced that the extra effort is worth it, because it's going to save so many people. Unfortunately, at least in the doctors of my or previous generation of mine are not so forthcoming. I'm sure this will change, because, you know, our generation is a little different. We are more honest with patients. We are less worried about our practice, things like that. I think this is going to change, because it's going to, but that's a social change. So that will does take some time. There
I
is
think
one
Vishwa has a question.
Good evening, everyone. I wanted to ask that in the question of Robert consenting to organ donation, but his wife's wishes being respected, if the roles were reversed, not the rules, but whether if the patient has not consented to organ donation and has said, I don't want to donate it, but their family decides to do it after their death, is it still ethical? And how far do we listen to the law in practice?
So currently the law in India only, the final thing for organ donation consent is the family. So the patient's own wishes, whether it is written or verbal, are not really taken into account at that point. But this is a rare situation that a family is aware of somebody's wishes not to be an organ donor, and then they would consent to donation. That is a situation I have never encountered, and I don't think will ever happen, because the family is typically inclined to do what the deceased person wishes were. So that is typically what we have also observed is, when you talk to the family, if they are unaware of the person's wishes, then they make their own decision. But if they were aware of the person's wishes, and if there is not too much resistance in the family, then they generally go ahead with the person's wishes.
Yeah, I have a follow-up on that. I mean, you had given an example of NHS. So in the UK, now they have the opt-out system,
They
right?
just started.
Yeah. So if he had an NHS card, then that would be the legal way to
In
go,
UK,
right?
in UK, yes. So in UK, if you are a registered organ donor, then you are a registered organ donor. You do not have to ask the permission of the family.
And if the family says no, they would still go ahead and do it.
Then you could still
Is
do
that
it.
right?
Yes. So again, see, I'll tell you one small story here, and I hope it's not too much time, but when this point was discussed, so before 2014, the Transplant Act was passed in 1994 and amended in 2011. Before the 2011 amendment, this point was hotly debated in the ministry, and I know it because I used to represent Vedanta in the meeting at that time. And you got to trust me, 9 out of 10 people said India is not ready for it, opt-out system. Why? Because they said, and this is very senior bureaucrats, and they were not wrong in their perception of how people could react to it. So they said that if you do this, and if tomorrow you take somebody's organs out and the family doesn't know, this will be similar to the mass sterilization that was done during emergency, and this will lead to the government falling the next day. This is exactly what that guy said. And I don't know, we are not the right people to judge people's perceptions, and they probably deal with people all the time. So maybe there was some sort of truth to what he was saying. So he was very sure about what we should not do this. So there is Dr. Utkarsh Tiwari, who's unable to mute himself. His question: what do you do with unidentified patients who are now brain dead? Would you take? A very good question. So there is a provision in the law for unidentified people and for prisoners. So sometimes, prisoners are not considered people who can give this thing. So people who are in prison or who are unidentified. So there is a provision in the law that after 48 hours of making attempts to identify somebody of their family, if nobody is being identified, then the hospital superintendent, chief medical officer, or the jail superintendent can give consent for organ donation for such people. Unfortunately, the way brain death and organ donation works, you do not have 48 hours. Typically you have like 6 hours, 12 hours, things like that. So it is very so far we have not encountered any situation, but yeah, if this happens, there is a provision in the law. Although if we could change it a little bit, then it will be much more useful. And what if they get identified later? Would the doctor and their team be sued for that? Possible, but the law would not support it, because there is clear provision in the law that if you cannot identify the relatives of a person for 48 hours, then they can be organ donors by the consent of the CMO, and therefore they will be well within the purview of the law, supported by the law. Is there a criteria for eligibility for becoming a registered organ donor? No criteria. So every person can become register as an organ donor. They just have to sign the donor card, which is on Noto website, which Organ India website. Several NGOs have the organ donor card on their websites. However, the most important thing is to talk to the family and tell them that you want to be organ donors, because ultimately it is their consent which will determine whether your wish is successful or not.
I think there's one more question. Ashvi?
Yes, good evening. Regarding what you said, that there is no criteria to organ donation, but shouldn't there be some, like if a person has some disease like HIV or hepatitis B?
Of course. So I may have sort of communicated a wrong impression here, but so for somebody to be willing for organ donation, there is no criteria. But typically, somebody who has a lot, let's say a liver disease or a kidney disease or heart disease, they will not be able to donate that organ, and it will be medically unsuitable for donating that organ at that time. So supposing there is a person who has got kidney disease, they may be willing organ donors, so they may not be able to donate their kidney because of medical suitability, but they may still be able to donate other organs. In some people, for example, there is a question on HIV here, which also addresses. So if there is a HIV positive person who is an organ donor, it is possible for HIV positive patients to be organ recipients from that patient, from the donor. But then if there is nobody on the list who is HIV positive and needs a transplant, then that donor who, although willing, their organs may not be utilized.
Okay, thank you.
Yeah. And then there are different laws for different religious groups, but for organ transplant, there is a single law, no difference based on different religions. Only one law for all.
Sir, I have one question, so which always comes in my mind. So I will say it in Hindi so that I can explain it well.
Sure.
So if A person is on the first number on the waiting list, okay, and the B person is second on the waiting list. If there is an organ donation happening in the different city, and the matching recipient is 1 number and 2 number, like A and B.
Yeah.
And if there is cost involved for procuring that organ from that one city to the second city, so like in ethical way, it goes to the number A1 patient, first A patient, but sometime hospital take that cost from the recipient. So what will happen in that case?
So I'll try to make it simple for everybody. So there are two patients on the waiting list. Patient number 1 lives in another city, and sorry. So there is this organ which has to be brought from another city. Okay. So not only there is cost of the organ transplant, but there is an additional cost of the team going to another city and bringing that organ. Sometimes this cost could be huge. For example, if you want to get an organ from Nagpur to Mumbai in a chartered flight, a heart, let's say, it could cost 10 lakhs more. The transplant cost itself is whatever lakhs, plus you got to spend 10 lakhs. Now, patient number 1, who is the first on the waiting list, cannot afford that 10 lakhs. So he says, no, I can only pay that heart transplant ka cost, not this additional money. But patient number 2 says, I can afford this extra cost, so I should get the transplant. What do we do in this situation? So in India, we give it to patient number 2 because it's not happening in the government hospital. If it was happening in the government hospital, then this additional cost will not be there, because then the government will figure out a way to take care of this cost. But in the West, where everything is either covered by the government or by the insurance, the patient number 1 will get the transplant. So therefore, when there is no confounding, now here your choice is that either you follow the ethical principle and give it to patient number 1, but how? So
But then how is it fair or even ethical that the person who can afford it
no,
is
so
going to get
not
it?
because of that. So what we do is we ask permission of the first patient. We say that this is an additional cost that is involved, which is unavoidable. So are you willing for the transplant with this additional cost? He says no. So then he has declined consent. So that's how you do it. It's it's a ethical gray area. Of course, it's a dilemma. But then that's the only way it can be done. But ideally, and there are attempts at doing this, but ideally what we should do is we should be able to balance out this cost over many transplants. So instead of charging 10 lakhs to that particular patient, what you do is you charge 1 lakh extra to each transplant patient. So over 10 cases, you would have that money. So when you need to go for an organ procurement in another city, you will be able to spend that money yourself, the hospital. So that way you balanced out the cost risk to everybody. And that is one way to do it. But there are several solutions to this. There have been suggestions that the government should fund this air transfers and things like that. So there are several solutions for this, but at this point, this is what is the most reasonable thing to do in India. But ethically, if there are no resource limitations, I would give it to the first patient. With resource limitations, I would give it to wherever it is feasible.
Yes, so now can we have I don't think there's any more questions. Can we have a picture with all the participants? I think
Yes.
Pankuri.
So I request all the participants to please turn on their cameras. We'll give 10 more seconds, then we
So
can have the
my hope is that I have just instigated into you the difficulties of what ethics in medicine or medical practice is. And trust me, transplant is just a more difficult ethical area. But even in your regular medical practice, you're going to encounter a lot of ethical dilemmas. And, be sure of that you're making the right ethical decision when you encounter such a situation. That's all. So if you make the right ethical decision, as far as you yourself are convinced that you're making the right one, then you'll sleep well. That's all.
Yes. Thank you so much, sir. So I think we can have the picture now. Pankuri or Prateek, could you help us with the picture, and Aboli too?
Yeah, so I see 4 screens. I request everybody to please stay still, and we don't know who's going to appear on what screen. So I'll start with the first screen right now. Smile, everyone. Okay, moving to the second screen, please stay. Moving to the third screen, please stay. And moving to the last screen. All right, done.
So it gives me an honor to thank Dr. Ravi Mahankar, sir, who is here with us today, despite his busy schedule. And I'd like to thank on behalf of MSAI and Organ India, who have put in an effort to make this webinar a successful one. And thank you very much, sir, for giving all the fruitful information regarding how ethics can play a vital role in organ donation process. So I'd also like to, extend my thanks to all the organizers who have been working really hard for quite a few weeks and making this webinar a successful one. And finally, to the participants who are here, who are super interactive, at the same time asking amazing questions out there to the speakers. So a huge shout out to you all. So I'm really glad that we all made it to this webinar. I also would like to apologize for the inconvenience caused at the beginning of the webinar of the number of participants who could join through this link. Post-webinar form, wherein you'll be providing the feedback as well as the speakers, which will also be shared with the speaker. So I'd request all of you to fill in the form. The same form will also give you an eligibility for the certification. And the QR code is being shared on screen. So those who are viewing online through YouTube, who couldn't be quite interactive due to the limitation of the questions being asked to the YouTube chat, but definitely you can give all your inputs through this form, like a detailed feedback or any other question. If you want it to be directed to the speaker, we will be sharing it with the speaker, and all the answers will be shared with you personally. So I think we can conclude the webinar here, and I'd like to thank everyone again. So we'll keep this QR code on for 15 more minutes, and the links are shared in the chat section. We'll be resharing it again. If you have any technical difficulties, you can reach out to us either to me. So I'll be sharing my mail ID as. For those who are attending online on YouTube, you can drop a mail to bpe@msai. Am I audible?
Yes.
So you can drop a mail to bpe@msindia.org. So I can give you access to this code as well, but the code will be accessible only for 15 more minutes starting from now.
Okay. Thank you. Thank you very much. Thank you, Dr. Mohanka.
Thanks a lot.
Thank you,
Thank
MSCI. Fantastic webinar.
Thanks.
Thank
Okay.
you so
Good
much,
night.
ma'am. Thank you. Thank you.
Night.
Thank you so much, ma'am. Thank you, sir.
Thank you. Thank you, sir.
Okay. Thanks.
Thank you, Dr. Neil. Very nice. Pankhuri.
Thank you, ma'am. Can we share the link again, Prateek? Like every 2 minutes.
Sure, sure. We'll do that.
Also reiterating that the form is consists of both certification as well as feedback. There's no separate form for certificates, so please do fill this form and we would love to hear your feedback. Raboli, please confirm if the code is visible on the YouTube video.
Yes, it is.
Nice.
It is.
Okay. Also, for those who have queries regarding certificates, the certificates will be mailed to your personal the same. Thank you so much for your feedback on chat as well. And for those who have finished the feedback form, you can leave the meeting. And thank you so much for joining us today. For those who have, joined through YouTube, we are giving you 3 more minutes to fill in the form. You can scan the code and fill in the form.
Neil, we have a query in the chat box regarding, so if you can answer
For
that.
those who have, am I audible?
Yes, Neil, yeah.
Yeah, so for the certificates, it'll take, nearly few months because it'll be given on behalf of both the organizations. So we'll send it across as soon as it's ready, and you'll be receiving it on your personal ID. Okay, so we'll be concluding the live streaming and the meeting. So thank you so much.